we have discussed much about pleural effusion, right? So this is another spectrum of pleural disease. This is pneumothorax. So as I have told earlier, what is the definition of pneumothorax? Anyone? Definitely, this is any amount of air accumulation in between the pleural space. So in case of pleural effusion, this is a minimum amount of fluid, more than 15 ml of fluid. This is pleural effusion, and any amount of air, this is called as pneumothorax, right? So in normal environment, there will be no air trapped in between the two layers of pleura. Okay. So this is the definition, air in pleural space. So why there is no, in normal environment or normal situation, why there is no air normally in between the pleural space? Because there are two opposite forces acting at the pleural space, right? One is the lung that tends to recoil inwards, and the chest wall that actually pushes the chest wall actually tries to push itself outward. So the inward force and the outward force that makes the pleural pressure negative. So the pleura, because of the negative pressure, the two pleural layers are adhered together with a small number of amount of fluid that acts as lubricant. So there is no actually potential space that can accumulate the air itself, unless there is a trauma or any rupture of blebs, right? So what is the major classification? Normally we can divide the pneumothorax as per etiology. That means one is spontaneous and second one is traumatic. As the name itself implies, what is spontaneous? That means there is no history of trauma. The air accumulates spontaneously between the two layers of pleura. There are no history of trauma or no history of accident or no history of any other pleural insertion of like any other iatrogenic causes, right? This is called spontaneous. And what is traumatic? That means there is definitely a history of trauma is there, maybe a road traffic accident, maybe blunt trauma, maybe sharp trauma, or maybe instrumentation inside the pleural space, right? So according to, this is the classification according to the etiology. So the spontaneous pneumothorax can be subdivided into another two parts. So one is primary spontaneous and another one is secondary spontaneous pneumothorax. Again, as the name itself suggests, that what is the secondary? That means there is underlying lung disease itself. The patient has underlying lung disease, such as the patient may have chronic obstructive pulmonary disease or asthma or bronchiectasis or any pleural or parenchymal infections like tuberculosis. That means where there is an etiology of the underlying lungs, the underlying lung parenchyma is affected, and that is the cause of the pneumothorax. Then we can call it as secondary spontaneous pneumothorax. Whereas where there is no underlying, the underlying lung parenchyma is absolutely normal. There is no underlying lung disease, but the patient develops pneumothorax spontaneously without any history of trauma. This is called as primary spontaneous pneumothorax. Okay. So this is primary spontaneous and this is secondary spontaneous. Okay. Next one is traumatic pneumothorax. So traumatic pneumothorax can be divided into two other parts. So one is iatrogenic. What is iatrogenic? That means doctor related or procedure related or instrumentation related. Okay. Suppose you are doing a biopsy from the peripheral part of the mass of the lung tissue. So suppose there is a suspecting bronchogenic carcinoma or suspected mass at the periphery of the lungs. So you are about to insert a needle to do a guided FNAC. or true cut biopsy. So you have to traverse the pleura. So there is a connection, actually the connection between the air and between the outside of the pleura and the inside of the pleura is created, the space is created. So that is the way where the air can enter through the pleural space. So this is clearly an iatrogenic pneumothorax, and another one is non-iatrogenic or traumatic pneumothorax. By a road traffic accident, by any sharp injury or stabbing injury or anything, right? Another entity that was previously, this was a old concept, artificial pneumothorax. So pneumothorax was created to heal the lung cavity itself. This is a previous concept. Actually, far before then the anti-tubercular drug was invented. At that time, where the tuberculosis has no such therapy, no such cure, then the tubercular cavity or the abscess cavity was resolved after doing an artificial pneumothorax. So if you actually insert artificially air inside the cavity, after some time the cavity will collapse by itself. This was called an artificial pneumothorax, but nowadays this is obsolete. Okay, so this is according to the mechanism of pneumothorax. So এগুলো জানিস, these are the types of pneumothorax. You have no idea about pneumothorax, right? In your physiology class or any okay. So there are three types according to the mechanism. One is open, second one is closed, third one is tension pneumothorax. Again, the name suggests itself the mechanism. Open, that means, what is open? That means there is an open connection between the periphery of the outside of the lung and through the pleura, right? Inside of the lung. Suppose the patient made a road traffic accident or a sharp object injury. Through the sharp object passes from the outside part of the lung to the inside, traversing the pleura. So the pleural tissues ruptures, and the pleural connection, actually there is a connection between the outside of the lungs and inside of the lungs. Air enters through the connection. So this is an open pneumothorax. That's just as simple as that. So the open pneumothorax itself actually carries significant risk of infection to the pleural space, because there is a potential space where the air and the bacteria can insert into the pleural space, right? Second one is closed pneumothorax. That means there is no connection from the outside to the inside of the lungs. There is no connection. The pleura is sealed from the outside and inside. So what will be the mechanism? There are certain blebs, or actually air containing spaces, which are called as blebs or bulla or cyst. There are different types of, these are the different types of, or cavity itself. These are the different types of air containing spaces. The mechanism of this I'll describe in later part. Okay, so rupture of this potential air containing spaces. So if the air containing spaces ruptures, if the cyst or the bleb ruptures, then the air from that space leaks into the pleural space, right? So that is causing the closed pneumothorax. Okay. Next one is tension pneumothorax. So it will give you enough tension. So that's why it is called as tension pneumothorax. No, not like that. So actually tension pneumothorax, it is a actually medical emergency. These two pneumothorax, open and closed pneumothorax, are not medical emergencies. Yes, they should be treated as early as possible, but tension pneumothorax is a medical emergency. So why? Because tension pneumothorax develops. So actually there is a mechanism of the, suppose there is an open pneumothorax or a closed pneumothorax. There is a connection, right? And if you are not treating the pneumothorax as early as possible, then the pleura, actually pleural tissue, creates a flap over the pneumothorax. Suppose this is a flap, okay? So if this is a flap and this is a connection, air is passing through, right? And during the inspiration, what happens? During the inspiration, the flap will inwardly reflected, like that. So the air enters, okay? And during the expiration, the flap will close the puncture wound. That means ki, one way valve and there is no outward going of the air. Understood? This is a simple mechanism, tension removal. So that is why the air is accumulating rapidly inside. So there is no way out. The air cannot go from the outside, from the inside, right? That means the pressure is intensely developing within a fraction of second, fraction of minute. That is why this is called as tension. At one point of time, the pressure will build up so much that the mediastinum itself will be shifted to the opposite side. And the cardiac function will be compromised because of the tension. Understood? That is why this is a medical emergency. Okay? So, what is the pathophysiology? Just I have already mentioned about this lung has the tendency of elastic recoil resulting in negative intrapleural pressure. So, in normal environment there will be no air inside the pleural space. But definitely at apex the pressure is more negative than the base. Okay? That is why in the apex there is a more chance of pneumothorax because the pressure is more negative. And this is, so just understand this picture. This is a bronchovascular sheath, right? This is an intact bronchovascular sheath where there are bronchioles, arterioles, venules and alveoli. So if there is, so this is an intact alveoli, right? Suppose the alveoli ruptures or there is a connection between the alveolus and the pleural space. So the air from the alveoli leaks through the pleural space until when the two of the potential spaces, the pressure of the two potential spaces will equilibrium, right? In equilibrium. So until that time, the pneumothorax or the air continuously enters into the pleural space. So that causes rupture of the alveoli and disruption of the bronchoalveolar sheath itself. So the air actually accumulates around the arteriole, around the bronchiole and around the venule itself. So and so this is the pathophysiology. Okay. So in case of primary spontaneous pneumothorax, as I have already mentioned that those patients who are developing primary spontaneous pneumothorax, they are tall, thin built. Because of the thin built and tall structure, the difference of the pressure will be and actually varies from the base to the apex, right? Because of the thin and tall structure. Okay. So that difference is so pronounced that it creates subpleural bleb or air containing spaces. Small subpleural blebs, that means air containing spaces are there and they rupture spontaneously, creating spontaneous pneumothorax. And secondarily, say in secondary pneumothorax, maybe the rupture of the cavity or bulla, that in case of cavitary pneumonia may lead to secondary pneumothorax. So what will be the physiological effect? Anyone? What will be the physiological effect of the pneumothorax? The total lung capacity will be increased or decreased? Decreased. Because air is accumulating, right? So the TLC will be the deduction of the vital capacity, the TLC and functional residual capacity, all will be decreased, right? And if the pneumothorax is large enough, occupying more than 20 to 30% of the lung surface area, then it will cause potential VQ mismatch, ventilation perfusion mismatch, and that causes hypoxia. So, but actually in case of primary spontaneous pneumothorax, তুই দেখবি যদি কোনো পেশেন্ট তোর কাছে আসে with a case of primary spontaneous pneumothorax, পেশেন্টকে তুই maybe you can incidentally find that this is a case of pneumothorax. Patient may or may not have any typical symptom of pneumothorax. Why? Because in case of primary spontaneous pneumothorax, the underlying lung is okay, normal. There is no pathology in the underlying lung, right? So initially the initial hypoxia, the patient, তুই যখন আরো query করবি about the history of, you should ask the patient in detail about the history, then the patient may tell that আমার প্রথম একদিন আমার একটু শ্বাসকষ্ট হয়েছিল, তারপর নিজে থেকেই ঠিক হয়ে গেছে. So that is the typical clinical feature of the primary spontaneous pneumothorax. Why? Because initially the hypoxia result from the shunting of blood. There is creation of shunt initially. But in case of primary spontaneous pneumothorax, the VQ is normal, right? VQ is normal, ventilation perfusion gradient is also normal because the underlying lung is normal. So this is a compensatory mechanism where the vasoconstriction occurs. After the compensatory vasoconstriction, that means the aerated area, less aerated area will be aerated after the later part. This is a compensatory mechanism. But in case of secondary spontaneous pneumothorax, as the lung itself is diseased lung, so there is the patient have already VQ mismatch, so there will be no compensatory vasoconstriction or no compensatory correction of hypoxia. So in case of secondary spontaneous pneumothorax, that is the reason why the patient will develop the severe hypoxia, and it will it will not abolishes until you put a chest drain or you actually pull out the air through the syringe. Okay, but in case of primary spontaneous pneumothorax, the patient may be asymptomatic. This is the reason. And as I have already mentioned, in tension pneumothorax, valve-like mechanism, one-way communication. In inspiration, there is indrawing of the air, but in expiration, the flap will block the passage. So, primary spontaneous pneumothorax etiology is rupture of the subpleural parenchymal subpleural emphysematous bleb at the apices of the lung, and the blebs are due to, probably there are different types of mechanism of forming a bleb. The blebs most commonly are formed by the continuous continuous reactive oxygen species mediated damage to the subpleural space and erosion of the, this is because of the smoking. Okay, so in case of smoking, chronic inflammation creates blebs which are located subpleurally, mostly at the apex of the lung. And যেটা আমি এক্ষুনি বললাম, the gradient of the pleural pressure greater from the lung base to the apex in taller individual, and the alveoli at the lung apex subjects to distended greaterly, right, than the base because of the difference of the pressure. So that means at the apex there will be more chance of pneumothorax than the base. And this is important, that the primary spontaneous pneumothorax has a chance of recurrence around 30%. Why there is a chance of 30% recurrence? Because suppose at the first episode, one bleb ruptures, okay, that is causing the pneumothorax. There may be multiple blebs. Another one may rupture after one or 2 years, right? If the patient continues smoking, then there is another chance of pneumothorax at the same or the contralateral lungs, because you never know that the bleb is not present at the contralateral lungs, right? So this is important for your MCQ, the genetical association of primary spontaneous pneumothorax. This is a syndrome called Bardet-Dubé syndrome. So this is generally caused by FLCN mutation, and there are other system involvements, and recurrent primary spontaneous pneumothorax will be there, and other disease such as collagen vascular diseases, Ehlers-Danlos syndrome, Marfan syndrome. So these patients may suffer from recurrent spontaneous pneumothorax. So symptoms, actually the patient characteristic will be tall, thin built, young, smoker individual in case of primary spontaneous pneumothorax. Sudden onset pleuritic chest pain and shortness of breath mostly develops at rest, okay, and definitely যেটা আমি কিছুক্ষণ আগে বললাম যে even the patient may be asymptomatic after some time, okay. So inspection কি finding পাবি, suppose you are dealing with a case of two cases, one is pleural effusion and one is pneumothorax. By doing clinical examinations, how can you differentiate between two? Any differentiating point? Very good. This is the only point. In both of these cases, there will be fullness of chest wall, there will be decreased movement of chest wall at the affected site, there will be decreased breath sound, decreased vocal resonance, but the most important point of differentiating between the two entity is the percussion. Dullness of percussion means you are dealing with a case of pleural effusion, and hyperresonant note on percussion, that means you are dealing with a case of pneumothorax, right? Now definitely the next investigations, in case of ECG, right axis deviation may be there, but probably this is in a case of tension pneumothorax, where there will be a shift of mediastinum to the opposite side, then there is a rightward axis deviation, RF amplitude will be decreased, right? Not in normal pneumothorax. And this is a typical X-ray finding of pneumothorax. So this is an area, you can appreciate that this is a affected area, site, left sided pneumothorax, right? This is a black area, right, compared to the right side. And so actually, can you describe that X-ray? Anyone? Can you describe? Hyperlucent or hypolucent? Hyperlucent. So this is an hyperlucent area of the occupying the entire left hemithorax, right? And the two important points of describing a pneumothorax is the collapsed lung. You can appreciate this is the collapsed lung. This is the collapsed lung. So the collapsed lung, the lung will be actually the lung collapses towards the hilum itself, towards the hilum like a fist, That বুঝতে পারছিস, like a fist towards the hilum. The lung collapses towards the hilum like a fist. This is the typical of pneumothorax. Another one is the evidence of visceral pleural margin. That এই margin, this is the margin. This is the visceral pleural margin. দেখতে পাচ্ছিস? This is the visceral pleural lining, right? এখানে এরকম কিছু আছে? নেই তো? So this is the visceral pleural lining and this is the collapsed lung. And the border is convex. It is not concave one. Okay? So hyperlucent area occupying the hemithorax, fish-like lung collapse towards the hilum, and there is visibility of visceral pleural lining. These 3 points you should mention while you are describing a X-ray of pneumothorax. And another important point, there are bronchovascular markings. That right side there are bronchovascular markings. Black and white spots are there. These are the bronchovascular markings. X-ray যখন পড়াবো তখন ডিটেইলসে bronchovascular marking নিয়ে ডিসকাস হবে, ঠিক আছে? বাট এটা এতটাই hyperlucent area that there are no bronchovascular marking present. Okay, this is a X-ray of pneumothorax, but this is also a case of pneumothorax, right? These two are the films of pneumothorax. Huh? These are not pneumothorax. Why? Because look at the border. The border is concave. এখানে border কি ছিল? Convex. The border is concave. So this is bulla, another air containing space, which is called as bulla, right? Okay. So now before doing a management of pneumothorax, you should learn how to measure. Actually, you have to assess how much pneumothorax the patient have. Is it small, is it moderate, or severe pneumothorax or massive pneumothorax? So there are certain criteria of measuring the size of pneumothorax, ATS criteria and Lights criteria. There are different types of criteria. Okay, so এগুলো মনে রাখার দরকার নেই. BTS criteria, suppose this is an ATS criteria, the apex to cupular distance. That means you have to measure from here to the visceral pleural lining, from the apex to the visceral pleural lining. If this is more than 3 cm, then you can call it a significant or large pneumothorax. And the most accepted one is the British Thoracic Society measurement. That measures the intrapleural distance, most probably at the level of hilum. If this is more than 2 cm, this is called as large pneumothorax or significant pneumothorax. এটাই মনে রাখতে হয়, more than 2 cm. Okay, intrapleural distance. And this is the USG of pneumothorax, where there is the barcode sign or loss of seesaw sign. So in case of positively motion lung or actually normally aerated lung, if you put your USG transducer, you can find that this is the no motion chest wall wave. So just like barcode, right? So these are types of barcode sign. This is the barcode sign. But in case of normally motion lung, there will be absence of barcode. There will be seesaw like sign. মনে হচ্ছে না এটা সিসোরের মতো দেখতে, এই যে এই এরিয়াটা, absence of barcode. But when there is pneumothorax, then no motion lung will be just as the barcode sign. তাই তো, মানে just chest wall এর মতো, there will be no motion. And CT thorax is also an important investigation of pneumothorax. It can detect very small pneumothorax as well. So what is the management of primary spontaneous pneumothorax? So there are different criteria of management of primary spontaneous. This is according to the BTS guideline. If the volume of the pneumothorax is small, that means less than 2 centimeter, then just give 100% moist oxygen and the pneumothorax will be dissolved by 2 to 3 days. Why? What is the mechanism? Why we are giving this 100% oxygen? Because the pneumothorax air contains the atmospheric air, that means nitrogen, more nitrogen, around 75% nitrogen is there, and if you are giving 100% oxygen, then there will be gradient between the nitrogen and the oxygen, and that air that contains the nitrogen will diffuses through the capillary, right? So there is a pressure gradient. That is the main reason of giving 100% moist oxygen. But if the size of the pneumothorax is more than 2 centimeter according to the BTS guideline, then you have to aspirate through the needle. Okay. The site of the aspiration will be 5th intercostal space, safety triangle or quadrangle. What is the boundary of safety triangle or quadrangle? Boundary of safety triangle? Anyone from your anatomy class? And why it is safe? No idea? So actually the upper point is the apex of the axilla, right? Next, the base is the 5th intercostal space. Okay? Medially there is the pectoralis major, right? So this is the triangle, and laterally suppose this is a latissimus dorsi, I think. And the aspiration should be done with minimum 50 ml syringe, with 50 ml syringe and 16 gauge of needle, wide bone needle, okay, at the safety triangle area you have to aspirate. Ki kore bujhbi je this is a case of pneumothorax and you are doing aspiration correctly? One is, if you are inserting the needle and put a negative pressure, then put a suction, then there will be sudden loss of resistance. That means you are entering into the pleural space and you are aspirating the air. Another one technique is, if you are filling the 50 ml syringe with 10 ml of water, then there will be bubbling inside the water if you are aspirating the air. So, but continuously aspiration of more than 4 liter of air is an indication of putting a chest drain and stop the aspiration. Okay? And this is tube, this is another, the last mechanism, the last part of management is called as tube thoracostomy or insertion of intercostal tube. দেখেছিস কোনোদিন intercostal tube drainage? দেখিসনি? ক্লিনিক শুরু হলে দেখবি, আমি দেখিয়ে দেবো কিভাবে করতে হয়। So indication definitely, one, in case of primary spontaneous pneumothorax, the size will be more than 2 centimeter and the patient is symptomatic. But in case of secondary spontaneous pneumothorax, the size will be more than 1 centimeter and the patient will be, if the patient is symptomatic, right? Second one, if there is presence of air and fluid together, hydropneumothorax or hemopneumothorax, hemothorax along with pneumothorax after a blunt trauma, okay, and if you are doing a pleurodesis. So what is pleurodesis? Pleurodesis, that means the space itself, the pleural space, that is the potential space where there is accumulation of air or fluid. If you can obliterate the space, then there will be no collection of fluid or air in future, right? So to prevent recurrence, there is a mechanism, there is a procedure, this is called as Pleurodesis. What is the mechanism? You are putting a chest drain, and this is in case of pleural effusion as well as in case of pneumothorax. You are putting a chest drain. After that, when the whole air or whole of the pleural effusion will be drained out, okay, then you should apply certain agents like providone iodine, talc, different types of agent. So that creates an inflammation of the pleural space. So that inflammation results in so that the neutrophilic exudates and fibrosis that results in adherence of the two pleural space and obliteration of the pleural space. So this is the safety triangle: pectoralis major, latissimus dorsi, base of axilla, and fifth intercostal space. Sorry, this is not the apex, this is base of the axilla, the upper part. And pigdal catheter should be inserted, small bore pigdal catheter. Pigdal catheter ki ICT ki segulo class, clinical class যখন হবে তখন দেখানো হবে. The other chest tube to ওখানে insert করলি safety triangle এ, right? So the other part of the chest tube should be connected to the water seal. Why water seal? Because to develop the pressure. যদি তুই ওপেন রাখিস তাহলে কি হবে? আরো নেগেটিভ প্রেসার হবে, আরো এয়ার ভিতরে ঢুকবে, তাই তো? So if you are connecting to the with a water seal drainage, then there will be pressure gradient, right? So the air or fluid itself will collects into the water seal drainage. And how will you confirm that yes, you are right, you are doing perfect procedure and you are putting the ICT in the pleural space and there is air? So one is, if you see bubble inside the that drain, and another one is swing will be there. That means in the chest tube, the column, the fluid column will swing with the inspiration and expiration, right? So there is swing. যখন ওয়ার্ডে যাবি, যখন কোনো চেস্ট টিউবের পেশেন্ট হবে তখন সামনাসামনি দেখবি, বুঝতে সুবিধা হবে, ঠিক আছে? Definitely this is an important question, how long the chest tube should be in place. Actually এটা তো আর রেখে দিতে পারবি না তুই সারাক্ষণের জন্য রেখে দিবি, that is not the point, right? So if the air leaks will be stopped, air leak will be stopped, and after the stoppage of air leak 24 hours you should observe, then you can remove the chest tube, ঠিক আছে? After stoppage of the air leak 24 hours after the stoppage of the air leak you can remove the chest tube. And if the air leak continues, কি কি কন্ডিশনে air leak continue হতে পারে? Suppose the patient is developing the pneumothorax and the lung itself is damaged and there is a potential connection between bronchus and pleura. This is called as bronchopleural fistula. Then তখন কি হবে? তখন যত চেস্ট টিউব দিয়ে তুই অ্যাকচুয়ালি এয়ার লিক আউট হবে আবার তো কালেকশন হবে, বিকজ দেয়ার ইজ এ কানেকশন বিটুইন দ্য ব্রঙ্কাস এন্ড প্লুরা, রাইট? দ্যাট ইজ সাজেস্টিভ অফ ব্রঙ্কোপ্লুরাল ফিস্টুলা. কিভাবে বুঝবি দ্য পেশেন্ট ইজ হ্যাভিং ব্রঙ্কোপ্লুরাল ফিস্টুলা? ওয়ান, the chest will not actually re-expand after 2 to 3 days. The swing will be there and the bubbling will be there. The bubbling implies air is present in the pleural space, right? So this is suggestive of bronchopleural fistula. In that case the chest tube should be in place, and after 3 to 5 days if the swing and bubbling will be there, then the patient should be advised to go for surgery. Video আসছে thoracoscopic surgery. Thoracoscopic surgery will be actually কি করে thoracoscopy-তে? ওই area of the pleura will be obliterated mechanically, ঠিক আছে? কোনো bleb or bulla যেটা থেকে rupture হচ্ছে or bronchopleural fistula will be closed by devices and the potential space, pleural space will be obliterated mechanically. কি করে? সারফেসটাকে, যে প্লুরাল সারফেসটাকে র করে দেয়, right, surgically. So that means adhere হতে প্রবলেম হবে না, ঠিক আছে। Definitely clinically decrease of dyspnea, the presence of breath sound. In pneumothorax there will be reduced breath sound. If the pneumothorax will disappear, then there will be definitely reappearance of the breath sound and change of percussion note will be there. That this is a case of pneumothorax. This is a visceral pleural lining, right sided pneumothorax. Can you appreciate that? This is a visceral pleural lining. This is pneumothorax, and after putting a chest tube, this is a chest tube. This is chest tube. So there are typical actually there are holes or pores inside the chest tube through which the air moves to the drainage area. So this is Pleurodesis. Definitely this is indicated in pneumothorax to prevent the recurrence, but in case of pleural effusion also, if the patient is having recurrent pleural effusion specifically due to malignancy, then you should advise Pleurodesis. And what are the indications of Pleurodesis in pneumothorax? Recurrent primary spontaneous pneumothorax, that means more than 2 episodes. Second, after first episode of secondary spontaneous pneumothorax, because secondary spontaneous pneumothorax is actually patient jodi barbar secondary spontaneous pneumothorax hoy, the VQ will be decreased further because the lung itself is damaged. So after the first episode of secondary spontaneous pneumothorax, because the secondary spontaneous pneumothorax has a higher recurrence chance than primary spontaneous pneumothorax because of the diseased lung. Second, if the patient, even if the patient is having primary spontaneous pneumothorax and the occupation of the patient is sea diver, marine diver or pilot, then after the first episode of primary spontaneous pneumothorax you should do Pleurodesis, because jodi pressure gradient change hobe pilot or sea diver der, so there will be another chance of pneumothorax in a very short period of time, ঠিক আছে। And bilateral pneumothorax, so these are the indications of Pleurodesis. So etiology of secondary spontaneous pneumothorax, most commonly COPD, bullous lung disease. In case of COPD, chronic obstructive pulmonary disease or asthma, there are formation of air containing spaces, bulla, which ruptures into the and the air inside the space leaks into the pleural space. That is causing the secondary spontaneous pneumothorax. After any certain infections, so infections, mind it, not all infection can cause pneumothorax, but certain infections that causes cavitary pneumonia that increases chance of formation of cavity, air containing spaces. The cavity ruptures and from that cavity air leaks into the pleural space, such as most commonly tuberculosis, right? Staphylococcus aureus pneumonia, pneumocystis jirovecii pneumonia, Klebsiella pneumonia, right? So these are the causes of pneumothorax, right? And okay, so symptoms of secondary spontaneous pneumothorax similar that of primary spontaneous but severe in nature, jeta ami bollam je because there are loss of VQ matching, loss of compensatory mechanism in case of secondary spontaneous pneumothorax, and the shortness of breath will be out of proportion of the size of pneumothorax because the lung itself is diseased lung. Lungs vital capacity is decreased already, and the small to moderate pneumothorax also decreases further the lung capacity. Signs are the same, that hyperresonant note, decreased vesicular breath sound, they are the same. So treatment, nearly every patient of the secondary spontaneous pneumothorax should be hospitalized and will be managed by tube thoracostomy, putting a ICT tube. So, but minimally symptomatic secondary spontaneous, minimally symptomatic, that means the pneumothorax size will be less than 1 centimeter and the patient is not symptomatic. Then BTS, British Thoracic Society, advises to follow this rule that the patient should be admitted definitely and close follow-up will be there, and definitely after certain days, after 2 to 3 days, if the patient develops hypoxia or any other respiratory symptoms, then you should order another repeat X-ray to see the pneumothorax is increased or not in size. So this is BTS guideline of pneumothorax. যেটা আমি একটু আগেই বলেছিলাম, if this is a primary spontaneous pneumothorax, এটা খুব important. If the size is more than 2 centimeter, aspirate with 16 to 18 gauge needle. If there is failure of aspiration or the aspirated air quantity will be 4 liter, then straight away go for chest tube drainage. One, and second episode of primary spontaneous pneumothorax, straight away go for this new tube thoracostomy to do Pleurodesis. And in case of secondary spontaneous pneumothorax, if the size is more than 2 centimeter or the patient is symptomatic, breathless, then always actually aspiration of of the secondary spontaneous pneumothorax, this is not recommended in other society, according to the other society, but yes, there is another opinion that you can aspirate with the 16 gauge needle. But আমরা যেটা করি, more than 2 centimeter or breathless, straight away go for tube thoracostomy in case of secondary spontaneous pneumothorax. This is another important scenario. After resolving the pneumothorax, কতদিন পরে তুই পেশেন্টকে বলবি যে you can do an air travel. This is important because air travel এর কি হয়, air travel এ pressure difference এর জন্য pneumothorax এর চান্স আরো বাড়বে, right? So in case of primary spontaneous pneumothorax, at least 7 days after resolution. Secondary spontaneous pneumothorax, preferably do a Pleurodesis before air travel and 14 days after the resolution. And this is another scenario, pneumothorax in people living with HIV. The most common cause of pneumothorax in HIV patients is, one is tuberculosis cavity rupture, second one is pneumocystis xerovici infection, followed by cavitary pneumonia, followed by rupture of the cavity and pneumothorax. Okay, and there are actually another drug that was used to treat and prevent the pneumocystis xerovici infection. That is called as pentamidine. So there was a concept of giving nebulization pentamidine nebulization in pneumocystis xerovici patients. So that nebulized pentamidine causes upper lobe pneumothorax. That is the reason why this therapy is stopped. Okay, nowadays what is the therapy of pneumocystis xerovici pneumonia? What is the drug of choice? What is the drug of choice of PCP pneumonia, pneumocystis carinii or xerovici pneumonia? This is cotrimoxazole. This is the drug of choice. Pneumothorax in LAM, that means lymphangioliomyomatosis. You have heard that name? No idea, right? You have heard a disease called tuberous sclerosis, TSC. জানিস এই ডিজিজটার নাম শুনেছিস? So in case of TSC, tuberous sclerosis, কি হয় tuberous sclerosis এ যে জেনেটিক মিউটেশন, this is autosomal dominant disease, TSC, tuberous sclerosis. So এখানে কি হয়, এখানে due to mutation there are formation of multiple cysts inside the lung cavity. Not only that, the lung is not only organ that is affected, but renal angiomyolipoma is another one feature of tuberous sclerosis. and cerebral subependymal nodule, saccharine patch. So these are the criteria of defining TSC, tuberous sclerosis. So in case of tuberous sclerosis, the lung parenchyma is affected by cyst. Multiple small cyst will be there, air containing cyst. The cyst will rupture spontaneously, causing pneumothorax. So in case of LAM, lymphangioliomyomatosis, there is a chance of recurrent pneumothorax. So in case of this disease, LAM disease, if you this will be better to do a pleurodesis at the first episode, because definitely there will be recurrence. Pneumothorax in tuberculosis, definitely after the rupture of the cavity, the air enters into the pleural space and there will be potential bronchopleural fistula formation, that is causing secondary spontaneous pneumothorax. So next one is tension pneumothorax. Definition to but definition jodi toke jigesh kore, mane if your external actually asks about the definition of tension pneumothorax, this is the ideal definition of tension pneumothorax. It is a life threatening condition where air enters into the pleural space but cannot escape. So the lung collapses and compression of the mediastinal structure. So air enters inside the pleural space during inspiration and cannot escape during expiration. So intrapleural pressure is more than atmospheric pressure during the expiration. So it is a medical emergency. As I have already mentioned, the mediastinal structures will be shifted to the opposite side and the cardiac chambers will be, the cardiac function will be compromised, the cardiac output will be decreased, right? So there is a heart failure along with the respiratory failure. This is definitely a medical emergency. So ki kore bujhbi the patient is having tension pneumothorax? One is the patient is severely short of breath, patient is hypoxic, cyanotic, even JVP will be raised. There are features of heart failure as well, okay, and hemodynamically compromised. That means the blood pressure will be decreased. So these are the, in pneumothorax, normal pneumothorax, none of these signs will be present. But in case of tension pneumothorax, all these signs will be present. So this is the mechanism. Jeta ami bollam, eta mention korchi na, okay. So it is a medical emergency due to rapid increase of interthoracic pressure, mediastinal structure compromised, decreased of that means cardiac output, venous return, and hypotension, definitely cardiac arrest if not treated earlier. So clinical examination, tachypnea, cyanosis, increased JVP, rapidly progression to shock, and this is very important. If the trachea is deviated to opposite side, then think about, in case of pneumothorax, then always think about tension pneumothorax. Normal pneumothorax, trachea will not be deviated, right? So in X-ray, if you find that the trachea is deviated, mediastinum will be shifted, then this is a case of tension pneumothorax. This is the trachea is shifted, opposite side. Mediastinum is also shifted, right? So this is tension pneumothorax. So emergency management ki korte hobe? Definitely put a oxygen cannula, oxygen mask, and immediate needle decompression. Needle decompression. Because the ideal management is putting a chest tube. Right? Chest tube ditei hobe in this case of pneumothorax. But chest tube arrange korte to time lagbe. Chest tube to time lagbe, arrange korte hobe, dressing korte hobe, onek kichu factor ache. So immediate needle decompression. Age bola hoto, just put a wide bore needle 16 to 18 gauge at the second ICS, second intercostal space. Kintu ekhon bola hoy put the needle at the fifth ICS. Put the needle, just a needle at the fifth ICS or second ICS, then the hissing sound of the air leaking will be there. Ekta মানে জাস্ট এয়ার লিক হওয়ার যে শো করে একটা আওয়াজ হয় সেটা সঙ্গে সঙ্গে তুই শুনতে পাবি। দ্যাট কনফার্মস that you are dealing with a case of tension pneumothorax. And arrange chest tube and arrange other things that actually chest tube dite hobe. So but important factor is never remove the needle before putting a chest tube. Okay, so just put a chest tube then remove the needle. This is a management of tension pneumothorax.